Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm really excited today to be sharing with you one of the success stories. It's not only a DPC success story, it's also a partnership between employers and a direct primary care practice within a community success story. It's a story that I learned of through Dave Chase's book, Relocalizing Healthcare, and I've had the opportunity to talk with some of the individuals who will be on this presentation and learn more in depth about it. And I think you're going to be very excited because it has implications for every direct primary care practice that's thinking about communicating with an employer. I want to introduce to you three of the speakers. Bryce Heinbaugh, who is CEO of IEN Risk Management in Ashtabula, Ohio. Maria Fowler, who is a pharmacist and co-owner of Hoffman's Pharmacy in Ashtabula, and Casey Billington, an RN, who is Chief Operating Officer and co-founder of Concierge Nurse Services. So, Bryce, I'm going to turn things over to you to help tell the story. Thank you.
Thanks, Larry. Much appreciated. I think the best start to this is having an understanding a bit about how we came together. And so I'll start off, lead us off, and then give Casey and Maria a chance to speak about their own background. So as Larry had mentioned, I'm CEO of a insurance firm, a consulting firm called IEN Risk Management Consultants. And I'm an accredited Health Rosetta advisor. Some of you are familiar with Health Rosetta, others may not be. There are 210 of us currently accredited across the country, and we're really committed to driving systemic change on the way employers purchase and deliver healthcare for their employees and families. I got into the business nearly 20 years ago after finding out that I needed to have emergency open heart surgery. At the age of 22, not knowing really where to turn, I began to, find my way through the healthcare system. How could I find insurance? This was prior to the Affordable Care Act. I was an uninsurable individual, and so started a firm. Fast forwarding a few years after that, went back to school and went into a healthcare MBA program in Cleveland, Ohio, where ultimately I shook some hands, made an acquaintance who specialized in self-funded health plans. He was the owner of an independent third-party administrator in Cleveland, Ohio. And from that point forward is when I really became committed to advising employers, middle market employers, maybe 100 employees to 2,500, on how to, if they weren't self-funded, how to get to self-funding, but also driving change through really, 3 or 4 years ago, the Health Rosetta model. So really doing business mainly in Ohio up until maybe 24 months or so ago, and the change came where we started going nationally after being published, blessed to be published in a few national pieces that one in particular was the Automotive News. And from that point forward, we started doing business really just about anywhere east of the Mississippi River. And so it's a pleasure to be here and to give you our story on this community in Ashtabula, Ohio, and how we've done what we've done with direct primary care, and certainly the care team that you're going to hear from here in a moment. So with that, Casey, would you like to give your background?
Thank you, Bryce, for the introduction. My name is Casey Billington. I am an RN, and I feel blessed to be here with you all and share our story about helping to improve the health of a community and how the DPC model is at the center of that. I am the co-founder of a company called Concierge Nurse Navigators, and we've been around for about 12 months now, and we've really helped to change the way that consumers are purchasing their healthcare services around our community, and primarily on the East Coast at this moment, with other consultants that we're working with. My background is nursing. I've been a solid organ transplant nurse for a little over 20 years, and I've worked for 3 large academic medical institutions, most recently running the quality department for one of those centers. So I understand the difference between quality and how those things can look different to different people, and why quality is so important when you're the consumer of healthcare services. I am again excited to be here with you all, and now I'm going to turn it over to Maria Fowler, who's our community-owned pharmacist.
Thank you, Casey. And thank you, Larry and Bryce, for having me here. As Larry mentioned, my name is Maria Fowler, and I am a pharmacist and the owner of Hoffman's Pharmacy in Ashtabula, Ohio. I was born and raised here in Ashtabula, and about my 3rd year at the Ohio State University College of Pharmacy, I was back home visiting family, and I stopped into Hoffman's Pharmacy where my family were customers. And I had asked the previous owner, David Hoffman, if he was hiring, and he said, sure. And so without a resume or an application, he said, you could just come in and start whenever you want. And so I started in 1990, and I haven't looked back since then. I've been very fortunate to be a part of an independent pharmacy family, and I learned quickly that there is a huge difference. This year, Hoffman's Pharmacy has been serving Ashtabula for 80 years. We've been here since 1941, and we are the longest surviving pharmacy in the area, whether it's chain or independent. And I will tell you that that's not by accident or because we're some savvy business people through the years. It's because the previous owner and his parent and grandparent and myself, as an owner and as the employees who work for me know, the most important thing when you're serving a community is to use the golden rule and treat people the way you want to be treated. And also all of the decisions that we make, we use empathy and kindness in making those decisions. And I honestly do believe that maybe luck and God are the reasons that, we have stayed a strong force in serving this community for so many years. I am honored to do that. And, for that reason, I'm honored also to be a part of this team. It's been an experience this last year that's been different than anything that we have done so far. And so I'm grateful for that. And I'm grateful for this opportunity to speak to all of the providers out there today. So thank you. On to Bryce.
All right. Thanks, Maria. Thanks, Casey. I think it's appropriate to share with you guys the background of this town, Ashtabula, Ohio. If you're familiar with Ohio at all, you would know we're about an hour east of Cleveland along the lake shore of Lake Erie. And what is important to note is, this town once flourished, and unfortunately, big industry, big business, much has either closed or left. And so we battle many of the same obstacles around social determinants, as well as socioeconomic factors that places like Youngstown, Ohio, or Pittsburgh, Pennsylvania, some Steubenville, Ohio, and even in areas of West Virginia, they battle the same situations. And so our median household income, I place it on here because many are astounded, for just $46,000, and 102,000 residents, where nearly 20% of them are at or below federal poverty level. So it's no surprise that healthcare can be expensive in a situation like this. But employers are the commercial payers in the market really are the most important to helping drive systemic change. So manufacturing, healthcare, government, your top 3 industries. We have 1 main hospital and 2 critical access hospitals owned by 2 different systems. One important thing that I'd like to mention, that there are no independent labs, imaging, or really primary care providers in the county. And so we had kind of a bit of a uphill battle getting started, but ultimately, as the story unfolds, you'll see what we've been able to do in just about 24 to 36 months' time. All right. the case study that I've been asked to share with you around Ashtabula is under Health Rosetta speak, we would probably label this as building of a community-owned health plan. And I think it's important for direct primary care physicians to understand this is really if you get your mindset and those in the community their mental models around what a community-owned health plan is, you'll start to see that the traction will build and folks will want to be a part of it. And so I want to share exactly how it started. And in this case study, the start of it began with our largest public school district in the county called Ashtabula Area City Schools. And I think it's important to note in 2018 is really when we had our first opportunity to meet with. We actually had asked for a meeting with both administration as well as union leadership. And we asked if we could gather in our local library, a big conference room there. We'd just like to share some information around ways of looking at doing healthcare differently. And so the administration had really opened the door opened to us in the administration after sharing a few stories out of Health Rosetta that really showed some big outcomes and results. And so gathering together with the union and even their labor representative in the room, we started to kind of shift the mental model that said union leaders and public school administration, you're all on the same side of the table. We're all fighting the same battle, and that is the misaligned incentives of the healthcare industry, unfortunately, and how crucial it is that we keep our dollars local, and instead of them being siphoned out of our local community to big insurers, big hospital systems, and large, big pharma. And so that this type of shift, it does take a little bit of buy-in. You've got to have some influence. But as you see on the slide, it shares with you that Health Rosetta was the key point that we wanted to share, and I will show you in a moment here that model if you're not familiar with it. Direct primary care was one of the very first topics that we spoke about. Nurse navigation, as well as again our number one goal of driving better health outcomes. And so at this time in the fall of 2018, I want the audience to understand, as I mentioned, there were no independent primary care practices in the county. And a matter of fact, I did not have a direct primary care solution at that time either. I was tongue-in-cheek hoping that they didn't ask me, well, who's your solution for direct primary care? And so as we were working closer to the public school district, I think this is appropriate where I give you the background and how we came to launching a direct primary care practice in Ashtabula, Ohio. Through really just happenstance, a local restaurant my wife and I were at for dinner, I happened to recognize a local physician. He and I had never met before. Matter of fact, I'm not sure that he'd even heard my name previously, but he and his wife were coming into the restaurant to sit down, and I had an opportunity to engage him just as he walked past the table. I said, hello, doc, and just, cordial hello. After probably a few minutes, I said to my wife, listen, I apologize. I've got to stand up here. I need to go introduce myself to this guy at this table because I need to have a conversation with him. And this is the best chance to just ask for it. And so I said, Doc, you don't know me. My name is Bryce Heinbaugh. And I have an opportunity to talk to you about something that's it's really considered called value-based primary care. And I heard you just recently retired from really at the time, a large health system in the from the Cleveland area. Many of you can put those things together. But Doc, I knew that you were an independent physician for many, many years. And a matter of fact, I also knew that you were the last freestanding independent family practice in this town before basically selling your book or your panel to the big hospital system. He said, Bryce, I just did my 3-year stint with this health system, and I said I will not continue. I got sick and tired of being sick and tired. My patient panel went to 3,100 as of most recent, and I just said I'm done. And I said, okay, Doc, I've got an opportunity that I think would interest you. Could we gather for a short meeting? And so what came to be at that point was having a conversation around the opportunity with the Ashtabula Area City Schools as my now friend, Dr. Jim Lambros, would become their direct primary care physician. And so this began again, an educational piece, not only with the school, but also Dr. Lambros, who was not technically familiar with this movement across America called direct primary care. And I shared with him everything that I gained from my travels with, again, Health Rosetta, but also the Free Market Medical Association, where I'd met a bunch of physicians who were very hungry to break away from traditional, fee-for-service business and really try their best at the value-based model under DPC. So, summer of 2019, we get the board approval to launch direct primary care, the very first strategy to implementing our Health Rosetta model. And we'll talk about again the model in a moment. But board approves that the direct primary care model for employees and their families on a voluntary basis. Again, they're not forced to elect or enroll as a member to Dr. Lambros's practice, but the offering would be there, and the public school would pay for all fees involved. There'd be no co-pays, no deductibles for the employees and or their family members. The sense of urgency became so high because in 2019, what we've started to recognize is the most expensive healthcare year in the history of Ashtabula Public City Schools happened. And so just so you know, on 400 employees, we unfortunately had a $10.5 million healthcare spend in 2019, $26,250 per employee per year. So we moved to launching direct primary care before the year ended in 2019, December actually, as it says here, and we kicked it off with live face-to-face meetings. We had to go in for change management. We had to explain to folks, hey, listen, this is a new model. This is time with your doctor. These are 30 or 60-minute visits, your choice, not a rushed 7 or 8 minute visit. And by the way, Dr. Lambros is going to be coming on site to the schools. There's 2 campuses, an elementary and a high school. He'll be on site a couple hours at each campus each week. And also with his local brick and mortar, we have the ability that your spouses and children can come see him. So it was an exciting time. Folks were probably still trying to wrap their minds around it. Wait a minute, a physician, concierge, we can text them, FaceTime, or meet in the physician's office. Yes, the answer is yes. 24/7, 365. Be respectful, but we had great response. We actually in that first implementation, we enrolled nearly 30% of their total eligible population, which is 1,100 total members. In that first 30 to 60 days, we brought in 30% of those members for DPC and sign up. Before I move on to this next slide, I want you also to understand it was not just a few months later. We had the opportunity through multiple meetings to gain acceptance not only from the union, administration, but also employees to firing their BUCA carrier after 18 years of the same healthcare plan all along for 18 years. We fired their BUCA carrier in the summer of 2020 during the pandemic and went to the full-on Health Rosetta model, which we have today with direct primary care, our concierge nurse navigator, as well as our community pharmacist, who we've also written into the plan, and a Center of Excellence program for high-cost specialty care. So As mentioned, some of you may be familiar already with Health Rosetta. I will not spend much time on this, but I want you to understand that this is the model itself. It should look like a container stack on a boat or a ship. And what is most relevant to this conversation is that center container, value-based primary care and patient stewardship. If you're familiar with Rosetta, you would know that we try to remove as many of the misaligned incentives of the healthcare industry as possible. It begins with us. Again, all dollars spent are disclosed. The plan that they will know where every dollar is going, from pharmacy to DPC to the nurses and the Center of Excellence program. But what we like to say is at the center of it all is direct primary care and nurse care navigator for any outlier patients or high chronic disease patients that we need to refer out to specialists or centers of excellence for care. As I move forward, I want you to understand that the title of this presentation, really was set up as when employers partner with DPC practices. But I want you to take it another step in your minds. It's really when communities partner with DPC practices, because what happens is, and I'll begin to explain, when one of your largest self-funded employers in your market falls to this new way of doing healthcare, direct primary care, the Rosetta model, achieving better health outcomes, what you begin to see are other employers in your market wanting to do the same exact thing. And when you can show them measurable, validated results, it grows like wildfire. And the concept of the community-owned health plan is exactly that. And so we began to leverage that this large public entity saw the value that we had to bringing in direct primary care and the Rosetta model. And in the same 12 months, we began talking with other self-funded employers and even employers who were not self-funded but had extremely high fully insured costs that were hampering their employees and their financial well-being. And so I share with you two here that came right away quick. A chemical company, chemical manufacturer in our neighborhood that received from their Buca carrier a 39.9% non-negotiable healthcare renewal, and they really couldn't sustain it. Another company, a plating company or chroming company locally with about 100 employees, were similar results of their fully insured plan. So we said the very first step, folks, in controlling your healthcare costs, before we do anything else, is to educate you around this model under value-based care, what it means to have a direct primary care physician, and let's get this DPC practice set up for your employees and their families on a voluntary basis to begin going after that 8 to 10% of the chronically ill that are driving your healthcare costs. And so we, at the same exact time, I mean, this was a very busy time for us, but at the same time, we began launching direct primary care in all three of these employer groups within 6 months of each other. And we got pretty good at replicating and standardizing the change management and the education to the employees. But at all three engagements in that first 30 to 60 days, we started to see we were hitting about that 30% voluntary enrollment. We were hitting getting 30% of the population to say yes to direct primary care. And within 6 months, all three of these employers started to tick up to 40% or higher of total population. More people started to hear about the great things that the DPC physician was able to do, Dr. Lambros, and the outcomes that we were driving. People at the water cooler said, "Hey, how do I get a part of this? I want to be a part of it. I need more time with my physician. I'm not getting it. I don't have a direct primary, or I don't have a primary care physician now." And so we started to see the uptick. What's exciting is to take it to the next level, and I'm going to turn it over here to Casey Billington to share with you exactly what we've done and put together in the model that you may recognize with all of these key key professionals to driving better health outcomes. So, Casey, with that, I'll let you take the reins here, and Maria as well, if the two of you would kind of walk us through how it works with these three employers and the members or the patients, what the patient sees from a frontline perspective.
Thank you, Bryce, for the history and the background, how we've gotten where we are now. And as Bryce mentioned, really the crux of what we're doing is to improve health outcomes, not only for the employees and their dependents at the employer groups that we work with, like the school system that Bryce had mentioned, but it's also for the community as well. Everybody benefits if we can start to improve health outcomes systemically. So as I had mentioned, what we try to do is build a multidisciplinary care team, but locally. And that may sound somewhat familiar to you when we talk about it being a direct primary care physician, pharmacy, nurse, and center of excellence type of program. And you may have heard of it referred to as advanced primary care. And it's very similar, and it's really kind of the model that we're moving to. It is patient-centered and it's quality-driven. So the DPC physician is the quarterback of this plan, and they're really the key to the success. The goal with a primary care physician is to have them on site at these employer groups. By being there, they're able to build a relationship with people that may not have had a relationship with a physician ever. They may have gone in, gotten their blood pressure medications, received their insulin, and then that was it. They moved on. They only had 5 to 7 minutes. So there was no time for education. There was no time to ask questions. And if they called, they didn't get to speak to the physician. They got to speak to the nurse or receptionist that was answering the phone. Really goes back to what Bryce had mentioned previously in terms of education. When we onboard these new employer groups, we provide a great deal of education to the employees on the services that the DPC physician has available to them, like the 24/7 coverage, the ability to text, the ability to FaceTime or use a Spruce type of app. And that really is key. The other component that we use is data and quality. So the Nurse Navigator program has access to claims data for the employees. And so when we see that someone is having an increase in prescription fills, maybe for one given area, we reach out to them. If they don't have a primary care physician and they're running around to a bunch of different specialists, we recommend to them that if their employer offers DPC, that they should sign up, because it would be better comprehensive care with one quarterback running the show as opposed to multiple different providers. When we've recommended those, it is extremely rare, I would say less than 3% of the time, that we've had people not engage with the DPC. Most of the time it's because they didn't fully understand the services that were available to them through DPC. And then, so with the Nurse Navigator component, the physician and the nurse work in tandem to try to ensure that that employee is getting the care that they need when they need it. And so we will help feed the direct primary care physician information in terms of claims that someone's maybe having, or phone calls that the nurses are receiving. I'm having all this knee pain, what should I do? Have you seen your DPC physician? Nope, I haven't. Should I start there? Yep, let's start there. And then if he orders anything, give us a call back and we can get you to an independent imaging facility to have your x-ray or MRI ordered, whatever the physician wants to do. Most of the time it's a two-way street collaboration between the DPC physician and the nurse, and they can communicate pretty efficiently back and forth via secure text messaging or emails. Rarely, do they need to pick up the phone, but it does happen at times. And then, Maria, would you like to give us a little bit of background on how you've integrated Hoffman's Pharmacy into this multidisciplinary approach?
Yes, thanks. So I I got the phone call in 2020 when really nothing, what good happened in 2020, but getting a phone call from Bryce Heimbach asking if Hoffman's Pharmacy would consider being the preferred pharmacy in this network because he saw the value in finding a locally owned pharmacy to be a part of it. It was such a blessing and a real eye opener too, because this is the first time, again, having been from this area my whole life, I have never seen a model like this where you really, especially, as the patient, you have a whole team of people starting with a great physician and then, an interdisciplinary team of people who help you through every step of whatever you need for healthcare. And I've never experienced that, but I can tell you that I realize you need a pharmacist as a part of the team, but having an independent, locally owned pharmacy was important because all of the members of the team, and especially the physician who leads this for us, he now has somebody who I've known him for all the 30 years I've been here, and we have a very good professional relationship, but he has access to me and to my pharmacy. He can send a message instantly right to me if he were to have a question. And then the same thing goes for everybody else on the team. We're all there to make his job easier and also to get the best healthcare for the patient. But we all also help each other out on the team. Frequently, I get a text message or a call from the nurse navigator, or we speak with the third-party administrator if there's an issue with billing. The patients get care because no ball gets dropped. Everybody does their part to make sure that the patient's getting what they need. I'm sure as healthcare providers, a lot of you who are listening to this you send out a prescription and maybe it's going to get rejected prior auth. You don't know what happens to it a lot of times after that. But here with this model, it gets handled, and a lot of times it gets handled without the physician having to have even too much trouble with that. I've never had access to a group of people like this before to get something resolved for a patient. So we're very fortunate to have that. And also a nice thing about every player on this team being that we are local people who we are invested in this community and we want it to do well. When Bryce comes to us with an employer and a new project, then you're going to do everything you can to save them money and insure them up as a school, for example, because as a community member, I want nothing more than to have strong schools in our area so other individuals and other businesses would want to relocate to this area. So it's very important to me on a personal note as a citizen and as an employer that this all works well. So we're very vested in the whole thing. And I feel that same way about all of the other players. And I would add too, just on a pharmacy note to any healthcare provider that sees this, working with an independent pharmacy is sometimes you wouldn't believe it, but you're going to get through to somebody and they're going to help you and get you answers if you need them. And that's very good. And also groups like this that are looking for a DPC provider, if you're someone out there who is a physician that's tired of, I'm spending all this time on EMRs and quotas of people that I have to see every day. And that's not really what you got into this for. I feel like this model is such a good fit for physicians like that really care about, like when they went to medical school and they said they want to help people, you really get to help people without being, just so numbers driven and so head down in a laptop trying to fill out all of the paperwork that's necessary. I feel like this is such a good model overall, and I'm grateful that Bryce introduced it to the area and that we are now working with, hopefully growing it with more and more providers. So again, I'm honored to be a part of it, excited about it, and I look forward to all the other programs we'll be working with. So thank you, and on to Bryce.
Thank you, Maria. I just want to go back to the concierge nurse navigator relationship a little bit more with the physician. So to go back to our example about how somebody comes in with knee pain and maybe the physician has determined that they need to see an orthopedist. So at that point in time, they can make a phone call or email the nurse navigator that has been assigned to that group. And that nurse navigator can really dive into the quality with the comprehensive data analytics program that we have and determine where the best physician is that patient should go see to potentially have a knee replacement or have an ACL repaired. And then the nurse can communicate that information to the employee or the patient and let them know that here's your choices. These are the highest quality physicians, surgeons for this particular diagnosis. And then they can make a choice on where it is that they would like to go based on the information there. Once the member goes and sees that physician, the DPC can then get that information back either from the nurse or from the patient themselves, depending on how savvy they are with their technology, to make sure that we're closing the gap on communication. Because really, what Maria had already mentioned is that communication is really the key to the success of this program. The reason that it works is because we're local and we are constantly communicating. There's assigned individuals that all have a vested interest in the patient to make sure that they're getting the highest quality care possible so that we're helping improve their lives. The last piece that I do want to touch on is the Center of Excellence program. And this is a program that Bryce runs with vast majority of his groups. And when the nurse and the DPC physician identify something that may not be able to be resolved locally within a community, say organ transplant or a complex cancer diagnosis, or maybe it's a major cardiac event, they can make a phone call to the nurse navigator and give us the history on that. At that point, the nurse navigator can make the phone call and the referral to the Center of Excellence program that we use most, which is Edison Healthcare. And at that point, Edison will take over and they will help arrange all of the travel, the lodging, and the meals for that patient and their spouse because they're already undergoing a stressful enough situation. We don't need to overly complicate their lives with trying to arrange for travel, but we ensure them that they're going to the highest quality center for that given diagnosis possible. We've had no turn downs of this service. Once people understand the value that a Center of Excellence program can bring to them and change their lives, it's an easy thing for people to invest in and agree to. And with that, I am going to turn it over to Bryce.
All right, thanks, Casey and Maria. I think it's appropriate too, just to state that probably one of the most repeated phrases that we say in Health Rosetta, and again, our founder, Dave Chase, says, the future of healthcare is local, it's open, and it's independent. And there is no truer statement than that. What we're describing, when I called Maria Fowler and said, Maria, you want to be a part of this awesome new healthcare model, of course she jumped at the opportunity. But what was really easy is that every one of those employers we spoke to knew Maria Fowler. They knew of Hoffman's Pharmacy, and they saw the value of, hey, a community-owned pharmacy has more time with patients as a direct primary care physician does. And they're not transactional. And it's not someone brand new out of school that's just, again, behind a counter helping, push people through the line. It's more than that. And Maria said it. She cares about our community and the population here and driving health outcomes. The money is staying local through her pharmacy with her employees and our families in this community. It's not going out to Wall Street. It's staying on Main Street. And that's a big part of this. And if for any reason at all, you're not cognitive of that, it is one of the largest selling points. If you're trying to influence a local self-funded employer's C-suite, you've got to get that mental model of local, open, independent. And this is the care team you get, and we're going to drive better outcomes because of it. Okay. So moving on, just a couple more slides here. Is I think it's important. The results. What have we been able to measure? So if these three examples that we're giving, there are others in the community, by the way. We have a handful of other self-funded employers that I'd love to add to this listing. But unfortunately, fortunately for Dr. Jim Lambros, we hit his total capacity under the DPC model. As many of you know, really and truly a comfortable level may be that 500 to 600 patients per year. Well, in less than 12 months, we hit his at 515. And the other employer groups that we have in this market, unfortunately, Doc is unable to take them on. And so these three companies alone are the example that we're giving here for this conversation. But we do have others that are seeking direct primary care in Ashtabula County, Ohio. Our chemical company, and again, just to put it into perspective, 100 employees, they were spending nearly $1.4 million a year on their healthcare spend. We reduced with our Health Rosetta model and direct primary care. The last 12 months or so, we've actually reduced their total healthcare spend after all DPC fees, after every prescription, 24% decrease in their costs. We were able to deliver employees in the beginning of our engagement a pay increase. Their healthcare premiums were going down. And after renewing their healthcare after the first 12 months, we were able to say, oh, by the way, your healthcare rates are going down again. Tell me where in America you hear these words 2 years in a row. Ashtabula City Schools, this is going to be a national case study. I feel strongly about it. Health Rosetta will probably make it a point to. I think it's important for you all to know that just in May of 2021, our city schools went to the ballot to have an operating levy placed on the ballot for. It was actually the first operating levy to be placed in 21 years on our local ballot. It failed in May. It failed by 200 votes. The purpose of the levy, the amount of money we were talking, was $2 million per year to help them stay in the black. As you see on the screen, out of our results and our outcomes, let alone, now these are financial outcomes, let alone health outcomes, which to us is our main goal. We reduced their spend coming out of 2019. We reduced their spend by 20% or $2.1 million under budget, the equivalent to what they needed to pass on that operating levy in May. This is really meaningful because what is really most important is those dollars did not leave our community. They did not go out to a BUCA. They did not go to a big health system. And those dollars can be reinvested right here. The plating company, for example, ended up with 52 enrolled employees on the healthcare plan and a total savings of 32% year over year. And so we've seen measurable results already. The work that Dr. Lambros has done and Maria Fowler at Hoffman's and our Nurse Navigator program, this is a really strong strategy that employers will have a really hard time leaving based on what we know we're doing, the lives that we're able to affect, the health outcomes. And when you hear from a community members saying, oh, you guys are the ones with that healthcare plan at Ashtabula City Schools, that's like nothing we've ever seen, or we heard all the great things, and we get the thank you cards and the letters, you know that you're doing really great work. And so I just want to share that with you. It's not just about the finances. It really is, there's greater good to this model and what we're doing, and certainly under direct primary care. So the key takeaways that I think are important to mention, as I took a phone call yesterday, by the way, I had a physician out of Portland, Oregon call yesterday and said, Bryce, I'm Dr. So-and-so. I've had a DPC practice for over 10 years out here. And unfortunately, as hard as I've tried, I've as many calls that I've made, as many connections as I've tried to put together, I can't seem to find a benefits advisor or a benefits consultant that does the work that you're doing and what I've heard about through Health Rosetta and other places. what am I doing wrong, by the way? Because I also am struggling to sell this concept to our local self-funded employers. In 10 years' time, I only have less than a handful. We have many individual members, but I cannot seem to get big traction with big employers. And so I think that it's valuable for you to understand that education around the status quo healthcare model and the way that, again, we ask this in all of our, we tee this up to employees when we go talk to them. We say, can you raise your hand? How many people here think the healthcare system is broken? And 90% of the room will raise their hand. And then we say, well, what if we told you it's actually working perfectly? It's working as designed for the profiteering and the price gouging that happens across America for Wall Street. Yep, they agree. But at that time is when you take the opportunity to start to shift the mindset. And so we talk about all the ways we do this. And again, it's really just the same conversation, whether we're in the C-suite or we have 100 employees in a room trying to get their buy-in, their emotional intelligence. And so I will say to you, I know that many of you have some highly effective circles of influence. Your social capital is probably one of the greatest, maybe either it's undervalued or perhaps you just haven't thought about it, but you just need folks to help you open doors to talking to CFOs, COOs, or CEOs of companies, even owners. If you happen to be, if it's your church group, if it's a country club you're a part of, or perhaps you serve on a couple nonprofit boards in your community, start talking to people about these things and educating folks. And all of a sudden, I believe strongly that you'll have some doors open and the ability to get in front of folks and talk about the value that you can provide in health outcomes and certainly lowering total spend. As I also said, emotional intelligence. And so this is anytime that you have an employer that either just makes the decision, themselves, a CFO making the decision by themselves, that's not how you get buy-in. We always suggest if there are unions involved, let's get some union leaders to the table. We want to have the opportunity to speak to them, educate, answer questions, and explain why this is the future of healthcare. And the sooner that they do it, the sooner they may see pay raises in their paychecks because healthcare costs are going down. I think it's important that you have to first win the emotional intelligence before really trying to drive it home. I also share with you the last piece on this slide is a book, a great read called The Go-Giver. And if perhaps you're looking at this in your own community, don't look at through the lens of how can I build my business? How can I get to that 500, 600, 700 patients as fast as possible? I once, my business has been in this community for nearly 20 years, as I mentioned. And I started off with, more of that mentality. I shifted about 10 years ago to giving and showing that I care and volunteering and being a part of this community. And I have to say, unfortunately, short on time, but I started serving on a lot of nonprofit boards, economic development boards, and other places. Once folks started to see that, boy, this guy is committed to this community and helping our underserved community, the most vulnerable people in our community, working middle class folks who, unfortunately, healthcare, the big healthcare systems have taken advantage of the most. I can say to you that things just start falling one after another, and the domino effect of systemic change begins to happen right in your own community. So being that go-giver and really helping connect other people, showing that you care, is probably one of the very first steps that I can say people will see that, they'll recognize it, and they'll want to do business, they'll want to see you grow. So with that being said, it's been a pleasure here today. Larry, I think you may want to, one or two questions that you wanted to pose for us.
First of all, I'd like to thank you, Bryce, Maria, and Casey for a fabulous presentation and for really the brilliance of how you've implemented the model in this respective community. Bryce, I do want to make this point, and then I have a question for you. One of the things that we created some years ago was called the Primary Care Innovators Network. And we created that as a vehicle to bring together docs and bring together employers in the same rooms to talk about healthcare delivery and healthcare expenses. And one of the things that I learned, and we did this in a number of cities, we did it in Houston, we did it in Cleveland, Chicago. One of the things that I learned is that the docs and the employers and the unions do not speak the same language. And they're talking, but they're just passing by one another and not knowing that the other is not understanding what they're saying. And the thing I learned from your work, Bryce, is the value of someone like you. You are an interpreter and a communicator. You're like, in a way, an anthropologist who's able to communicate with the docs, but most importantly, you have the respect and the ability to communicate with the employers and the unions. And uh, this is to all the DPC docs who are listening to this presentation. Having somebody who's Health Rosetta trained, who is not making money off the incentives that are hidden, but is making money based on payments from employers so that they're incented to deliver the best product to employers is really critical. And so I realize there's only 210 trained, unfortunately, but there will be more coming online, Dave Chase tells me. And I would just like to say to everyone, finding someone like a Bryce so that they can do that work for you and with you is, I think, a real critical step going forward. The other thing, Bryce, I wanted to ask, I happen to know from our earlier conversations that you guys are so successful, you're recruiting docs to the DPC practices. Do you want to comment on this?
Sure. Thank you. Yes. First, let me just, I'm going to address real quick, Larry. You said something that is important about the communication, and sometimes I will say to you, I really take pride in meeting people where they are. It's very easy. If I wanted to go into a room, and even with a CFO or a CEO of a company, a manufacturer or other type of company, if I wanted to talk over them about healthcare and using fancy acronyms and speaking in clinical terms, or I could do that, but I will epically fail, because what I've noticed in my 20 years of doing this, CFOs, CEOs, the C-suite, they're not in healthcare. They don't know it. They don't understand it. They're spreadsheet folks. They're looking at margins. They're looking at dollars and cents. And so it starts with being very basic and very simple. When you're talking about healthcare change, keep it simple. And so if perhaps we go in there talking about population health and chronic disease drivers or disease management, prior authorizations, guys and gals, you'll lose them, and they will check out, and you only have a short amount of time to win their minds and hearts for this model. So keep it simple. Secondly, Larry, your question or statement about recruiting physicians. The answer is yes. We've been every market we go to, we look. The very first thing is what, and we use dpcfrontier.org, great website. But we look at what DPC practices are nearby in that market, and I typically look for the pure DPC practices, not hybrid. I really want, well-aligned physician practices. If there's not a DPC in that market, we do look to recruit. Some of the areas that right now we are focusing on, I will tell you, are more rural than they are big market cities. But West Virginia, Western Virginia, Western North Carolina, these are areas that we have a great deal of employers and employees in these areas that are lacking direct primary care, we're doing this model just as everything we've said, but we're doing it without DPC, and it can be so much more effective. And so we're seeking physicians there. Ashtabula County, Ohio, as I mentioned, we continue to win more self-funded employers. We just this week or this month, we were awarded the city of Ashtabula, a good-sized municipality. Dr. Lambros can't take on the patients. We are kind of at a standstill with, okay, well, who's going to be our DPC physician for those folks? The county government has also given us a bit of a nod that says, if you find it your next direct primary care practice, we too would be interested in this. Well, at this moment in time, Casey and I have spent a lot of time trying to recruit, taking physicians to dinner, trying to explain, yeah, we're an hour east of Cleveland, but, if you like to snow ski, Western New York's within an hour, Cleveland, Pittsburgh, nearby, and if you like to boat, you're there. So we'd love to talk to you if you're interested in West Virginia, Western Virginia, or Western North Carolina, as well as here in Ohio.
So did you not, Bryce, have some contact with a couple of brothers, DPC practices up in Erie, Pennsylvania?
We certainly did, yes. Isbicki Family Medicine, I believe, the first DPC practice to really file as is in the state of Pennsylvania. However, these folks are near their capacity. Patient panel is getting fuller, these two brothers, and currently they are only interested in staying right there in Erie, Pennsylvania with our client in Erie. So still that struggle is real, but I will say too, very important, we've continued to talk to the folks at University of Cincinnati, the residency program for family medicine down there, trying to recruit possibly some new physicians. Don't go to the big systems. Think about starting out in direct primary care and working with a Rosetta advisor to feed you your first few hundred people.
I was just down at the University of Cincinnati Department of Family Medicine last week. They have a very strong network for an urban area of now networked DPC practices, and hopefully that will create a pipeline going forward. And this is to the rest of the DPC community. I've been arguing this for a long time. We need to get very intentional and strategic about growing the pipeline to direct primary care, from medical students to residents. And I'm not sure that we've really gotten as thoughtful about how best to do that. But I think to grow the DPC movement, I think that's one of the essential things. So I'm going to bring things to close here and say thank you, Casey. Thank you, Maria. Thank you, Bryce. What you've done is amazing. And if I have my way, there will be a documentary one day that will go out to the public, because I think what you've done, you are a model for the country, and I think people just need to learn about that in a compelling way. So thank you very much for sharing your experience and your hard work with our community. And I would also just like to say it's unfortunate that Dr. Lambros couldn't be with us today. I know he's with us in spirit. He will get to watch this, so he'll get to hear what you said about him. But thank you to Dr. Lambros for stepping up and being
Absolutely.
willing to return to the career that he loved, using the DPC model. So thank you all very much.
It's been a pleasure. Thank you.
Thank you.
Thank you, Larry.